imagine that what can we do with those 30%, right? We can build more hospitals, we can maybe take a little bit more of health education messages as well, but it just, we got stuck into a lot of losses, a lot of, let's say, value-added activities actually, that did not factor in the patient and the outcome. Also to take that a little bit more, to understand where I'm standing today as a system. 5 patients are dying. 5 patients die every minute because of unsafe care. So this number is shocking, and that's happening, unfortunately, in many countries around the world. Some of them might be privileged, like, for example, what we have here in UAE. Some of them will be underprivileged. They don't have enough resources actually to do that, but that's happening across the globe. So today, the system got actually stuck in an area that again lost the focus of what's really important here. So 44%, so you can imagine a doctor going, let's say, 10-hour shift. So out of those 10 hours, 4 hours, 40 minutes are actually spent on non-value-added activities. Writing, documenting things away from the patient. So the patient is here and the doctor is actually doing office work. If you have visited a doctor maybe recently, you will see that pattern a lot, right? So they are writing and you're talking, but they are writing. So the complexity of the system actually, and the more ways to improve actually the system, especially from an IT perspective, they came to be converted doctor to writers somehow, and that also again took the clinicians from the focus of the patient to something else. Then also you have a big problem when it comes to what we call overutilization of the healthcare. So the prescription, or what we call overprescription, actually, the insurance think that 64% of the care provided today is actually done in a way that's overutilized or overprescribed. We don't do what's really right. We do more than what's right, more than what's needed. A couple of other factors, maybe it's good to go through them here. Then, so after all of that journey with the current healthcare system, or let's say the healthcare of the history now, hopefully, the healthcare of history, is that we came to a point that says, okay, that's not sustainable. We're wasting a lot of time, we're wasting a lot of effort. We took the providers away from the patients because of this whole administrative work that is associated with each patient encounter. So, Professor Michael Porter is a professor of economics out of Harvard University. He came back with a concept back in 2007 in a book that he wrote with colleagues called Redefining Healthcare. So within that book, he came up with the idea of value-based healthcare as a term that focuses really on patient's outcome. What are we doing for the patient? And then also to minimize the cost, because as we said, this is not sustainable. The healthcare system cost is going up without any limitations. So, and then in Harvard Business Review also he made, like, to complement his quote actually, what he wrote in the academic back in the days, how to make that implementable. And he came up with those 6 pillars for a value-based healthcare. And one key aspect here that you can see is that building an information and technology platforms that support the new, let's say, healthcare ecosystem, passing the past. So that was also an inspiration for us as a co-founder, as a team as well. So the main idea of the value-based healthcare is, although that it's vaguely defined, by the way, so if you ask someone about what does value-based healthcare, might answer something and then the next will answer something else. So, but it's definitely moving away from fee for service, which is if you go to a hospital and you got, for example, to see the doctor, then there will be an invoice or a medical claim generated that's be paid for this encounter. So you might feel better or not, we don't care, we're gonna pay anyway, right? So the point that you walk in and you got to be seen by a physician or a doctor, the point that you're gonna get payment associated with that. The outcome of this, let's say, prescription is not part of the equation. So that's what they call fee for service. To something, that's the new paradigm shift that we're talking about, the value-based healthcare, is that you need also to focus on the outcome as well as the reducing the cost. And that's what drives the value at the end of the day. So also the IGI has built very interesting models about the movement that we are witnessing actually, and what are the key aspects that can transform the healthcare from the past to the future. And they came up with what they call the triple aim and then the quadruple aim. So the triple aim was focusing on improving the population health, which is a very important term, especially after the COVID-19. So the population health aspect, which means that we want to focus on the healthy, creating healthier population, and working on the prevention a little bit more. So not only sick care, not only to wait the people till they get sick and then they go to the hospital and then get the payment, but actually focusing a little bit more on how to make them healthier as well, to prevent actually the sequelae of disease in the future. So also to improve the quality, and that's something very obvious, but also to reduce the cost. So the quality of care shouldn't be driving a higher cost actually. It might be the opposite. That's part of the triple aim, sorry. And then the quadruple aim just came to enhance that a little bit. It's a newer, and that's the most, let's say, recent model now of care, delivery of care, which added actually something amazing here, which is also enhancing the provider actual satisfaction. So this part actually. So if you think about it, yes, we are asking physicians, clinicians, nurses, pharmacists to contribute to the care of the future, which is driven by value, without actually focusing on them as a people, as a human who want to be also included. They want also to be satisfied, not burnt out, not spending too much hours actually and taking their human actually aspect of their life, or taking the life actually out of their job. So the main idea here is also to reduce the burnout actually, which is a very common problem in physicians, nurses alike, especially in the more intensive care unit, the emergency rooms, and all of that. So the quadruple aim is dictating, let's say, a paradigm shift, moving from sick care to be more of healthcare. So this momentum actually is also going across the region now. So I've seen amazing actually updates happening maybe in the UAE a little bit of earlier actually, in Saudi Arabia also recently, with the creation of NAFIS as a unified health platform or health exchange platform to connect actually the defragmented system, right? And also to create what they call health clusters, which means that segregating a multidisciplinary ecosystem of providers, primary healthcare, hospitals, and even ultra-specialized, like the medical city, into one area to make the population health actually done in a better way. It's what they call capitated actually care. So, and also in UAE, yes, probably Malafi, which is another health exchange initiative, actually, of healthcare exchange of data initiative in Abu Dhabi, as well as NABUD in Dubai, as well as RIAYTI by the Ministry of Health. So those are all trying to connect actually the disparate system, the silos actually within the healthcare into a better, let's say, platform that companies like us can connect in a better way because you have at least an infrastructure. So, yeah, that's an interesting thing. So you cannot actually, the process that we created the world with need to be changed. That's, we cannot actually change the new world without changing the process of thinking about the new world. So for us, we came on that momentum actually, and TachyHealth has been 3 years now. We started in Delaware back in 2018, and the US, and then in Dubai since 2019, and in Saudi Arabia 2020, and also now in Egypt as well in 2020 as well. So the main idea is that we work across the value chain, trying to make it better for everyone, right? So again, not working on the ultra minute problem that's actually creating only or solving this piece of the puzzle, while the remaining part are actually all broken. So we're trying also to work on the value chain, as I said, working with the provider as well as the payer to provide a more better coordinated outcome with lowering the cost as well. So the quadruple aim is actually always a North Star for us when it comes to the development